Hi everyone! We have now come to Wound Management in Primary Care Part 2. I'm Dr. Lee. I'll run you through the presentation. This is the outline of my presentation. Are you ready? Let's go! So what is debridement? It is a process of removal of non-viable tissue and contaminants from a wound to promote healing. Why do we debride? The necrotic tissue or slough, which can house bacteria and serve as an obstacle for wound healing. The availability of nutrients and oxygen and presence of ischemic tissue make this an ideal environment in which both aerobic and anaerobic bacteria to multiply. Debridement will remove non-viable tissue, reduce bioburden, and the presence of biofilms within the wound. Therefore, it will encourage formation of granulation tissue in the wound bed. For a chronic wound to heal, the molecular and cellular environment of the wound must resemble that of a healing acute wound. So now, when do we debride? It is always indicated when there's a buildup of non-viable tissue in the wound bed. All chronic wound has biofilm that will hinder wound healing. Hence, debridement should be done at every visit. How to debride? We have mechanical debridement, we have autolytic debridement, sharp debridement, enzymatic debridement, and biological debridement. Sharp debridement is also known as conservative surgical wound debridement. We use scalpel, scissors, curette, or forceps to remove the devitalized tissue. It can be done by the bedside, but there's risk of damage to blood vessels, nerves, and tendons. So it should be done by trained paramedics or doctors that are able to distinguish tissue types and understand anatomy well to reduce the complications. The second type of debridement, which is mechanical, it is a non-selective type of debridement. It has potential disruption of newly formed tissue and it is painful. The examples such as scrubbing technique using gauze, the pulse lavage, also known as water irrigation technique, is a form of mechanical hydrotherapy that uses a pressurized, pulsed solution to irrigate and debride wounds of necrotic tissue. The wet to dry dressing is not recommended. They use a piece of gauze and it is moistened with a cleansing lotion. Then it is put on the wound and allowed to dry. After the dressing dries, the dead skin sticks to the gauze and comes off wound when the bandage is removed. The autolytic type of debridement is the slowest method among all types of debridement. Therefore, it is not suitable for patients in sepsis. It is painless. This method of debridement uses the body's own enzymes and moisture beneath a dressing to break down the non-viable tissues and become liquefied. Therefore, maintaining a balance in moisture is important. Examples are hydrocolloids, hydrogels, and transparent film. The fourth type of debridement is the enzymatic type of debridement. It is a highly selective debridement method and it is also less painful. It is done using an exogenous proteolytic enzyme, which is the papain, or collagenase that will chemically liquefy the hardened, slough, and necrotic tissues. We should cross-hatch black esca before applying an enzymatic debriding agent. This type of debridement it is not recommended for patients with known sensitivity to the product's ingredients. Also remember, collagenase should not be used with silver-based products. The biological type of debridement uses maggots. There are two species of maggots. Malaysia, we usually have Lucilia cuprina. Following shows the mechanisms of action using the maggot debridement therapy. All these are the contraindications of maggot debridement therapy. Please go through it carefully. We have now come to the second part of the presentation, which is wound care. We will talk about treatment recommendation. How is everyone doing now? Are you still following me? This algorithm can be found in Manual Wound Care 2014 by KKM. It is theoretically developed based on the time concept, which we have learned in part 1. It intends to be a simple, quick, practical guide in general principles of wound bed preparation and wound care. It is done for those healthcare providers who are not familiar with wound management. Do not forget about the systemic factor, which is also important. When we do a wound assessment, we start with saying how big was the tissue necrosis or slough. We use 25% as the cutoff point. Then, we see if there's any wound infection. The next step, we classify the wound according to its moisture and exudative level. Then we come to wound type 1 to 8. The next 3 pages is the summary of different types of wound and suggestion of different types of dressing and usage of antibiotic if it is needed. You can pause and read them one by one. So the summary is different type of wound, we use different types of dressing materials. Only infected wounds needed antibiotic and it should be based on CNS report of infected tissue. This is a comprehensive chart which is done by the wound care team PKD Kapong, which already explained what we have just learned in the previous slides. So after this, we'll talk about wound cleansing. Wound cleansing is a process of removing inflammatory contaminants from the wound surface. These contaminants can impede healing and increase risk of infection. Contaminants are the necrotic tissues, excess exudates, foreign objects, and also the infected tissues. We have 2 types of wound cleansing solutions, the non-antiseptic solutions and the antiseptic solutions. It will be discussed later in other slides. There's 2 types of non-antiseptic solutions that we commonly use in general practices. The normal saline versus the sterile water. So you can see that I highlighted the sterile water. In this battle, sterile water wins as it doesn't support the growth of nosocomial bacteria like the normal saline. It is a hypotonic solution that can be reused again when it's kept tightly. Antiseptic solution is used for cleaning the dirty and infected wounds. We commonly use the superoxidized solutions, example dermacin and hydrocin. They are good bactericidal, virucidal, fungicidal, and spongicidal. They block the inflammatory process and may help in biofilm removal. We soak the gauze with superoxidized solution and it is to be applied on the wound for 10 to 15 minutes. They also have long shelf life once it's open. It can be used within 30 days. Another commonly used antiseptic solution, the PHMB solution, helps to soften and remove the slough. It can remove and reduce the biofilm formation. It is less painful. However, it is costly. The same method is used, but it is soaked in the PHMB solution and it is applied to the wound for 10 to 15 minutes. There are other antiseptic solutions such as povidone iodine, hydrogen peroxide, sodium hypochlorite, acetic acid, and Usol. These solutions, besides painful on application, it also can cause harm to the normal tissues. However, short-term use may be permissible. We will now talk about wound dressing. It is a very important topic. Let's pay attention. Characteristics of ideal wound dressings are as follows. We will talk about some examples of modern dressing. The film dressing, it is used to protect against contamination and friction. It can maintain moist surface and prevent evaporation. It is adherent and it acts as bacterial barrier. And it is transparent. It helps in facilitate the wound assessment. It is also waterproof and breathable. However, there could be fluid collection. When we remove the film, there's a possibility of stripping away newly formed epithelium. The dressing change is about 2 to 5 days, depend on the wound. We use hydrogel to rehydrate, debride, and deslab the wound. It can be used as cavity filling. Hydrogel often provide moist environment and reduce pain in dry wound. It is used as a desloughing agent and promotes granulation. We need to use secondary dressing on top of hydrogel. To reduce the maceration of the peri-wound, we can apply skin barrier. The frequency of dressing change is 2 to 3 days. Note that it should not be used on highly exudating wounds or where anaerobic infection is suspected. These are the examples of hydrogel that can be found in the market. Hydrocolloid provides moist environment. It also absorbs exudates. It often acts as a bacterial barrier. The advantages includes cleanse and debrides by autolysis. It is always very easy to use. It is also cost-effective. It promotes granulation tissue. It is effective for low to moderate exudating wounds. And it is also waterproof. The disadvantages are it has an unpleasant odor. It forms a yellow liquid gel. It is difficult to use in cavities. It sometimes causes maceration of skin around the wound. We commonly change the dressing every 2 to 5 days. Here are the examples of hydrocolloid. Do you know which one is used in your clinic? Example of calcium arginate is caltostat. It absorbs wound exudates and also can maintain moisture. It is economical and easy to apply. It has hemostatic properties, so it is effective to stop bleeding wound. However, it is not helpful in dry wounds, and it needs secondary dressing. We usually change the calcium arginate every 2 to 5 days. There is a number of foams available in the market. It is commonly used due to its absorbent properties, so it is good in highly exudative wounds. It is specially designed for cavity wounds. It provides protection as it is bacterial and waterproof. The downside is it may adhere to wounds if exudate dries out. Foam is often used as a secondary dressing or as cavity fillers. It also can be used with silver dressing. Hydrofiber is good in managing heavy exudating wounds. It also helps to maintain moist healing environment. It has longer wear time. It will become gel layer-like. Therefore, it is comfortable upon removal and reduce risk of maceration. It also can be used on infected wounds. However, it is not helpful in dry wounds. And it also needs secondary dressing. Frequency of change is 2 to 5 days. Charcoal is good in reducing odor, but it needs secondary dressing and is sometimes stick to the wound bed. Charcoal needs to be changed every 2 days. Silver can reduce bacterial bioburden in infected wounds. It is usually impregnated in other forms of dressings, such as silver and gel, silver and foam, silver and hydrofiber. It is bactericidal, but sometimes the dressing will discolor the wound. We can change the dressing every 2 to 3 days. Do note that it is for use 2 weeks only to minimize toxicity towards keratinocytes and fibroblasts. Multifunction dressing, it is also known as the polymeric membrane dressing. It contains surfactant that can provide autolytic debridement properties. It contains superabsorbents, helps in managing and absorbs exudates. It can also fill in the contour of wound bed. It contains glycerin to maintain good peri-wound, prevent sticky to wound bed and control odor. The semi-permeable cover of foam helps in increasing moisture vapor transmission rate, making the foam able to absorb more liquid. It has ability to modulate exudates from heavy to dry wound bed area. But it is not suggestive for heavily exudative wound. The frequency of dressing change is every 2 to 5 days. Honey has antimicrobial properties that can be used for debride or desloughing wound. It also has anti-inflammatory properties. Honey contains surfactant that helps in bactericidal effect, and it helps in reducing smell of the wound. However, it might have some stinging pain and also risk of maceration, as it will increase exudate. Iodine-based dressing is the only material that can break biofilm and maintain no biofilm recurrence. It has antibacterial properties, and it also has autolytic debridement properties. It is not for hyperthyroid patients. Collagen is used for enhancing tissue granulation and epithelialization. Therefore, wound usually close faster. Do note that it is not for dry and infected wound. We have come to the last topic of this lecture. Antibiotics. All wounds are expected to be colonized, but not all wounds are infected. Therefore, there is no role of prophylactic antibiotic. Antibiotic is indicated only if wounds appear clinically infected, either locally or systemically. Now, how do we do wound culture? Commonly used is the Levine technique. Start with identifying 1 cube of clean wound tissue. Rotate the applicator for 5 seconds while applying enough pressure to produce fluid from the wound tissue. Remember, specimen should not be taken from exudate, eschar, or necrotic material to avoid contaminant. This slide is from the National Antimicrobial Guideline 2019. I've highlighted the antibiotics used for abscess and cellulitis. If you have the wound culture sensitivity, please treat accordingly. This slide talks about the diabetic foot infections antibiotics. I've highlighted the mild infection as we primary care usually treat as outpatient. But you can see that IV is needed for moderate and severe infections. Congratulations! We have come to the end of the presentation. I have some take-home messages to share with you. Debridement is a crucial step for wound bed preparation. Always use appropriate modern dressing based on your own assessment. Know your dressing material well and use it wisely. All wounds need to be cleansed thoroughly before applying any types of dressing materials. Evaluate the wound every 2 weeks and change the dressing materials if there is no positive outcome. I hope this lecture helps in your future clinic practices. Thank you.